Hi, everyone. This is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Thank you for joining the Journal Club. Today, I have the great pleasure of sharing with you on the Journal Club the manuscript, which was our lead article titled Low-Grade Serous Ovarian Cancer, an Expert Consensus Report on the State of the Science. And this is going to be presented and discussed by Dr. Rachel Grisham, who is at the Memorial Sloan Kettering Cancer Center. Also invite everyone to listen to the podcast on this particular article because I think it's incredibly informative, and it was such a pleasure interviewing Rachel as well. So we would like to obviously welcome her, and we want to, of course, welcome as many questions from the audience as possible. Before we begin, I would like to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording, and we ask that everyone please keep your microphones muted so everyone can hear the presentation. If you're having any difficulties or questions, please send a message on the chat, and our technical support will assist you. Again, I would like to encourage everyone to participate and ask questions. And now, of course, obviously, we'll begin the Journal Club. And I would like to, again, thank Rachel for her time and thank her for submitting this article to our journal. And we look forward to her presentation. Thank you, Rachel.
Thanks so much, Pedro. I really appreciate the invitation. And David Gershenson and I had so much fun doing that podcast with you. So thank you so much. And excited for this Journal Club today. And hopefully we'll be able to have some great questions and interaction about the treatment of low-grade serous ovarian cancer, which really has changed quite a bit over the past decade and hopefully soon to change more with impending results of clinical trials. So this paper is actually an expert consensus report on the state of the science for low-grade serous ovarian cancer. The coordinators of this consensus conference that led to the development of this paper were David Gershenson of MD Anderson, myself, Rachel Grisham of Memorial Sloan Kettering Cancer Center, and Brian Slamovitz of Mount Sinai. And the idea was to bring together kind of experts in the field, leaders both in the pathology field, medical oncology, gynecologic oncology, surgery, radiology, and basic science to give an update on where the science currently is for the treatment of low-grade serous ovarian cancer and areas of unmet need and areas of active investigation. The conference met over a one-day period in October of 2022, which led to the development of this paper. There were key questions that were put together by Dr. Slamovitz and Dr. Gershenson and myself, which were then addressed both before, during, and after the conference to come up with these consensus opinions. Of course, low-grade serous ovarian cancer is a relatively rare form of ovarian cancer, accounting for less than 10% of cases of ovarian primary peritoneal and fallopian cancer diagnosed each year. It's oftentimes diagnosed in younger women and has a longer median overall survival, but can be complicated by significant morbidity during that time. Research has progressed since our last consensus paper, which was performed in 2019, and this is an evolving field as new molecular targets become available. One of the major issues that was discussed during this consensus conference was what is the definition of low-grade serous ovarian cancer? And it's really interesting because the terminology that we've used to describe serous borderline disease or serous borderline tumor and invasive low-grade serous ovarian cancer has really changed through the years. And it can be incredibly confusing when we look at the different terminology used to describe these precancerous and invasive cancerous lesions. So one of the main goals of this conference was to define in a clear way what is invasive cancer, what is not invasive cancer, and what are situations where we might consider using chemotherapy or other systemic therapy for treatment of this disease. And so the paper includes actually a table that kind of outlines both our older terminology and our present terminology based on WHO 2020 definitions, and tries to better define for the average reader what is invasive cancer that requires consideration of systemic therapy and what is non-invasive precancerous lesions. There are rare cases where high-grade serous ovarian cancer can be found in conjunction with low-grade serous ovarian cancer. These occur in less than 5% of cases and remain an area of active investigation. However, there was significant discussion about when we might consider to treat a patient like a high-grade serous ovarian cancer versus low-grade serous when these mixed cases do appear. Now, biomarkers are something where there remains to be a lot to be learned, and in some cases, maybe are being used a little too early before we have definitive evidence to show that they are a clear biomarker predicting for response. Now, this is the case both for the use of targeted therapies like MEK inhibitors and also for the use of endocrine therapy, where the consensus opinion was that we do not yet have a clear biomarker that predicts for response to treatment with these therapies, and therefore would not deny a patient without a MAP kinase alteration or without PR positivity the opportunity to receive these potentially active agents. Now, it's of course standard recommendations that patients with ovarian cancer undergo germline and somatic tumor testing at the time of their initial diagnosis. We feel that this applies as well to patients with low-grade serous ovarian cancer. Although low-grade serous ovarian cancer is not felt to be driven by presence of a germline BRCA mutation, there's of course always the risk of misdiagnosis, and we would not want to miss a patient that potentially has high-grade serous ovarian cancer that's been called low-grade serous ovarian cancer, who could have a potential BRCA mutation. Somatic testing is also important for these patients, given that the presence of MAP kinase alteration has prognostic implications. And speaking of prognostic implications, there are other prognostic implications we look at as well. So somewhat different to what one might expect, patients with younger age of diagnosis, when they're diagnosed with low-grade serous ovarian cancer, are associated with worse prognosis. And in several different studies, we've used 35 as kind of that cutoff for younger versus older patients, with shorter overall survival in patients that are diagnosed at a younger age. Residual disease at the time of initial surgical debulking is also a poor prognostic indicator, while patients that have presence of a MAP kinase alteration, which would most commonly be a KRAS mutation, are associated with improved prognosis regardless of treatment. Imaging is something that we talk about a lot in low-grade serous ovarian cancer. Since patients are diagnosed at a younger age, there can sometimes be a desire to use less imaging. However, CA-125 is also less predictive for these patients. So in general, the members of our consensus panel did recommend routine imaging for any patient diagnosed with advanced low-grade serous ovarian cancer. While there's not one optimal imaging modality, generally the panel members did prefer the use of CAT scan over PET scan for routine monitoring and recommended the use of pelvic ultrasound for monitoring of residual ovary in those patients that do have fertility preserving surgery performed for early stage disease. Fertility preserving surgery is considered in patients that have stage 1A to 1C1 disease and selectively in patients with more advanced disease. However, that would not be a standard of care. For those patients that are diagnosed initially with advanced stage disease, stage 3 or 4, primary surgical debulking is preferred. We really try to avoid the use of neoadjuvant chemotherapy if we know somebody has low-grade serous ovarian cancer. This, of course, is one of the many reasons why it's important to have a solid tumor sample, such as a laparoscopic biopsy sample or a core biopsy sample prior to initiation of neoadjuvant chemotherapy, so that we can confirm if a patient has low-grade serous or high-grade serous ovarian cancer. While HIPEC remains an area of active investigation across multiple different types of ovarian cancer, we do not recommend the use of HIPEC for patients with known low-grade serous ovarian cancer outside of a clinical trial. We do not recommend the use of CA-125 by itself as a monitoring strategy for patients with advanced stage disease, as this can be less predictive in patients with low-grade serous ovarian cancer. We do recommend the use of bone density monitoring for patients that are treated with an aromatase inhibitor, as this can, of course, increase the risk of osteopenia and osteoporosis. For those patients, both at the time of their initial diagnosis and with those diagnosed with recurrent disease, it's of course very important to engage with an expert gynecologic oncologist for consideration of surgical debulking. Unlike in patients with high-grade serous ovarian cancer, where we generally have relatively strict rules that we use to decide whether a patient is a candidate for a secondary or rarely a tertiary debulking, for those patients with low-grade serous ovarian cancer, we generally are willing to accept some level of residual disease at the time of debulking for recurrent disease, given the relatively lower response rates to systemic therapy. For those patients with recurrent disease, we do consider use of molecularly targeted agents such as MEK inhibitors, as well as the use of chemotherapy, endocrine therapy, bevacizumab, and of course, clinical trials. We do not routinely use immunotherapy for treatment of low-grade serous ovarian cancer, and it is exceedingly rare to find an MSI-high tumor in patients with low-grade serous ovarian cancer. So generally, we would limit this use to those patients that are on a clinical trial, though there are currently several clinical trials enrolling in Europe looking at the use of immunotherapy in patients with this disease. Now, I think oftentimes people refer to low-grade serous ovarian cancer as being a disease that's not responsive to chemotherapy. That is not, completely accurate. Patients with low-grade serous ovarian cancer do respond to chemotherapy, but the response rates are, of course, lower than they are in high-grade serous ovarian cancer. But that doesn't mean that chemotherapy should not be considered for patients with this disease, both in the upfront and the recurrent setting. However, because of these lower response rates, the consensus opinion was that the standard definitions of platinum sensitive and platinum resistant really don't apply to this disease and really shouldn't even be considered as a standard terminology for low-grade serous ovarian cancer, similar to how we're in some ways questioning the use of this terminology in high-grade serous ovarian cancer now, and do not necessarily feel that a patient that has platinum-resistant disease should not be able to receive platinum again in the future. While we don't have a definition for standard adjuvant therapy in patients with low-grade serous ovarian cancer, this remains an area of active investigation with an ongoing international phase 3 study which randomizes patients to treatment with adjuvant chemotherapy followed by aromatase inhibitor or aromatase inhibitor alone, and hopes to answer that question of how do we best treat our patients in the adjuvant setting after primary debulking for low-grade serous ovarian cancer. But of course, clinical trials, both in the upfront setting and in the recurrent setting, are the best way for us to answer questions about what the optimal treatment is for these patients. And some exciting clinical trial results that have been recently reported at ASCO and more results to come are hoping to accelerate progress for treatment of this disease. Namely, recently, Brian Slomovitz presented the results of CDK4/6 inhibitor in combination with aromatase inhibitor for patients with recurrent low-grade serous ovarian cancer at this year's SGO annual meeting. So that study showed a very promising response rate to that combination of 23% in patients with recurrent disease. Similarly, at this year's annual ASCO meeting, Susanna Banerjee presented the initial results of the RAMP 201 phase 2 study, which showed that the combination of dual MEK/RAF inhibitor avutometinib with the FAK inhibitor defactinib had an overall response rate of 45% in patients with recurrent low-grade serous ovarian cancer. So now it's kind of an exciting time where we're finding new active treatments, both in the upfront and recurrent setting, and hopefully being able to better individualize the care of our patients. And this is the beautiful visual abstract that was put together by the journal, and I really like it a lot. But thank you so much for your attention, and I welcome any questions or any areas of discussion.
Well, Rachel, thank you so much. We really are honored to have you join our journal club. And I have to say that that's probably the best overview that I've ever heard of low-grade ovarian cancer in such a brief amount of time. So congratulations to your ability to convey all of that information. And I agree with you. I do want these slides because I think it encompasses all the important topics of low-grade ovarian cancer. I wanted to actually before we get into the questions on treatments and some of the topics that you addressed, what would you say? You mentioned initially about the biomarkers and the tumorigenesis of low-grade ovarian cancer, and you alluded to this also in the podcast, and I think that you did a really great job. And I was wondering if you can share with the audience as well your thoughts on where we are as it pertains to biomarkers and tumorigenesis of low-grade.
Yeah, thank you so much, Pedro. And this is something that I think is so important and such an active area of investigation. And because MAP kinase alterations have prognostic implications and are potentially predictive, but we don't actually yet have data to show that they are predictive of response to treatment with targeted therapies like MEK inhibitors. And so the reason I say that is because when we look at low-grade serous ovarian cancer, so more than 50% of patients with low-grade serous ovarian cancer will have some type of MAP kinase alteration if we look deep enough with next generation sequencing, which is of course routine now, which is giving us more and more information about these patients. And so within that family of MAP kinase alterations, the alteration that we most commonly see in these patients is a somatic KRAS mutation, which will be found in about 33% of patients. And then less common alterations can include other RAS alterations like HRAS, NRAS, V600E BRAF mutation, which occurs in about 6 to 8% of patients, NF1 mutation, and then other alterations like MAPK1 and MEK1 and other alterations that can be seen. And so when we look at patients before we were even using MEK inhibitors for treatment, and we look at these retrospective studies that have been published out of MSKCC, one of them was led by a very talented researcher called Beryl Manning-Geist, who's a fellow I have the honor of working with, another led by Dr. Gershenson's group at MD Anderson. These show that patients that have a MAP kinase alteration, such as a KRAS mutation, have improved prognosis regardless of treatment, with never having received a MEK inhibitor. So patients that have a MAP kinase alteration have a good prognostic indicator. They tend to do better no matter what they're treated with. Now, then when we look at that and we look at our clinical trials where patients were specifically treated with MEK inhibitors, such as the 2 large phase 3 studies that were done, one with trametinib, the other one done with binimetinib, both of those studies found that patients that had a KRAS mutation or a MAP kinase alteration had better response rates to treatment with the MEK inhibitor than those that did not, better PFS to the MEK inhibitor than those that did not. But the test for interaction in both of those studies was negative. And that's because they had better prognosis. So whether the patients were treated with MEK inhibitor or with chemotherapy, they tended to do better. Now, if they got the MEK inhibitor, their extent of doing better was greater. And so if these had been larger studies, it might have been predictive of response. We can't say that definitively yet. But although we see numerically better response rate and PFS in those patients with a MAP kinase alteration that are treated with a MEK inhibitor, we can't say yet that it's a predictive biomarker. And so the reason this is important is for several reasons. Number one, when we're designing a clinical trial, because we know this is a prognostic indicator, we have to account for it, right? So we should generally stratify for this since we know it affects how patients respond to treatment. And then it also can help us to better inform our patients. So a patient that does have a KRAS mutation is more likely to respond to a MEK inhibitor. So if someone's having bad side effects, we might want to say, you know, your response rate is higher with a MAP kinase alteration. It's not necessarily predictive. And if you don't have a MAP kinase alteration, it doesn't mean you're not going to respond. But if that patient does have a MAP kinase alteration, you might encourage them to try to push through the side effects a little bit more, as they would be expected to have a longer progression-free survival on that treatment than someone that does not. And so, I think it's a really interesting question that we continue to gain more and more information about as we enroll more patients to these clinical trials, and learn a lot more.
Great. So I see that there's so many questions coming in on the chat as well, but we'll start with one of our fellows, Dr. Luigi De Vitis from Italy, of course. Now, although I think he makes his residence now in Rochester, Minnesota. So Luigi, you want to proceed with your question?
Yes, thank you, Dr. Grisham, for this wonderful summary. And so panelists recognize a difference between serous borderline tumor with invasive implants and advanced stage low-grade serous ovarian cancer. So my question is, in which cases, if any, of course, would you consider adjuvant chemotherapy for serous borderline tumor with invasive implants?
Thanks, Luigi. So yeah, this is another area where there's still some debate. And so with the updated WHO guidelines for pathology, we now do consider serous borderline tumor with invasive implants to be the same disease as low-grade serous ovarian cancer. However, ESGO guidelines still differentiate the two and consider serous borderline tumor with invasive implants to be a separate disease and actually do not recommend systemic treatment. However, in the United States, we generally do consider to group these together, and would consider chemotherapy. So while there's not one clear definition here, we generally take into account the extent of invasion and the number of invasive implants. But definitely for a patient with serous borderline tumor, who has multiple sites of invasive implants, I would consider the use of adjuvant chemotherapy following surgical debulking followed by aromatase inhibitor. And this is something that varies by region in terms of how we define it and treat it. But we know that these patients that have serous borderline tumor with invasive implants have probably at least a 30% chance of recurrence with low-grade serous ovarian cancer. And so I do consider adjuvant treatment for those patients if it's more than one isolated site of invasion.
Great. Rachel, we'll go to one of the questions from the chat. Bizan Monsef from Iran, and the question is, what is your approach when pathologists report indeterminate grade on a serous carcinoma?
Well, that would be hard. Yeah. So I guess, so what I would do is I would take into account the P53 status. So of course, high-grade serous ovarian cancer generally has a P53 mutation present in more than 96% of cases. Low-grade serous ovarian cancer generally P53 wild type. So if the pathologist is unable to grade as low-grade or high-grade as grade 1 or 3, or is calling it grade 2, then I would ask for P53 staining. And then if possible, would also do somatic tumor testing to look to see if there's presence of a KRAS or BRAF mutation. If the tumor is P53 wild type or there's presence of KRAS or BRAF mutation, it's more likely low grade. If it's P53 mutant and does not have a MAP kinase alteration, it's more likely high grade.
Great. Another question from the audience was, why is suggesting germline testing when we know low-grade serous carcinoma is BRCA negative?
Yeah, no, great question. And, traditionally, when we first started doing germline testing, we excluded our low-grade serous ovarian cancer patients from it. But really, the risk of doing that is too high. So national guidelines do recommend that all patients with ovarian cancer can receive germline testing. And so if this is available to our patients, we want them to be able to receive it. Because sometimes, as we've seen, as our colleague from Iran, sometimes the pathology can be unclear. And so the risk of a misdiagnosis and missing a BRCA mutation is really too high. And so as long as there is a way to have that testing done, we still do recommend that it be performed.
Very well. We'll go back to our fellows. We'll go to Seda Sahinakar from Turkey. And Seda, you want to proceed with your question?
Yes, thank you, Dr. Grisham. According to which criteria do we decide whether to use chemotherapy or hormonal therapy as adjuvant therapy in low-grade serous ovarian cancer?
Yeah, it's a really hard question, and it's an area of ongoing study, of course. And so we now have in the NCCN guidelines the option for both chemotherapy or endocrine therapy or chemotherapy followed by endocrine therapy as options for patients patients with advanced disease who have undergone primary debulking surgery? And the answer is that we have no prospective data yet to guide us in making that decision. Of course, there's an ongoing international phase 3 study that hopes to answer this question, GY019 being led by Dr. Amanda Fader and Dr. Gershenson, which by randomizing patients to chemotherapy followed by letrozole versus letrozole alone will hopefully answer this question for us. However, when I have a patient that does not wish to go on to that study, or if a patient is being treated in an institution where that study is not an option, I generally take into account the extent of disease. If a patient has residual disease after surgical debulking or had stage 4 disease, I do prefer chemotherapy followed by letrozole. If a patient had a complete gross resection or early stage disease, stage 2 or early stage 3 disease, I would consider use of letrozole alone. But for those patients with advanced stage disease or any residual disease, my standard of care is generally 6 cycles of platinum taxane chemo followed by letrozole maintenance.
Yeah. Thank you, Rachel. And another question, actually, interesting question. With regards to the transformation from low grade to high grade. So in a patient who had, I guess, an original diagnosis of low grade, when there is a manifestation of a recurrence, is one then needing to perform a biopsy to document that this is still low grade, or could it be high grade in the recurrent setting? And how do we manage that?
Yeah, so it's pretty rare that that happens. And in these cases where we do have mixed, it's, maybe 5% of cases. In these cases, we do always ask the question, is that truly a transformation or is that 2 concurrent malignancies? And oftentimes we don't know. So I think somebody who you've been following and have already pathologically diagnosed recurrent disease previously, you don't necessarily have to do serial samples over time to keep confirming that it's low-grade serous ovarian cancer, because it would be relatively rare to transform or have concurrent high-grade serous ovarian cancer. But for patients at time of first diagnosis, I do always try to do a biopsy to confirm the histology again.
Fantastic. I think the next question comes from Jorge Hagel. He's in Venezuela, and he wants to ask about response to endocrine therapy. Jorge, do you want to go ahead with your question?
Yeah, thank you, Dr. Grisham. And is there any way to predict which patients may have a response or resistance to endocrine therapy?
Thanks, Jorge. Yeah, we really don't have clear evidence to show that hormone receptor positivity or extent of hormone receptor positivity predicts for response to endocrine therapy. Now, this is somewhat limited by a couple of different factors. Number one, most patients with low-grade serous ovarian cancer are estrogen receptor positive. And so there's not like a large number to look at that are estrogen receptor negative, and about 60% are progesterone receptor positive. And then the other factor is, of course, that unfortunately our response rates to endocrine therapy are relatively low, so 13% or lower generally across studies. But we don't have any definitive evidence that hormone receptor positivity is associated with response. So I generally would not exclude a patient from use with endocrine treatment based on their level of estrogen or progesterone receptor positivity. And we just really don't have the data to say that it's a clear indicator for this disease.
Yeah. Rachel, going back to some of the questions from the audience, and this one is more kind of surgical question, and that is pertaining to lymphadenectomy, routine lymphadenectomy in low grade. And I think that, for many years, it was tradition that, well, that's how you stage it and that's how you proceed. Is there evidence that we can potentially stop doing lymphadenectomy in low grade ovarian cancer?
So disclaimer, I'm a medical oncologist, not a surgeon. So number one, always have your surgery performed by an expert gynecologic oncologist. But, in general, yes, the rate of lymph node metastasis is lower in low-grade serous ovarian cancer. And so, one might want to limit their extent of lymph node dissection at the time of surgical debulking based on the appearance of the disease. But I don't think it can be, I wouldn't limit lymph node evaluation.
Mm-hmm. Very well. I think this one is going back into your realm of expertise. The question on when you give adjuvant hormonal therapy, how long do you keep a patient on it?
Yeah, I know it's a great question and one we don't have an answer to. So, of course, the pivotal study that really led to us routinely doing this as a standard of care was the retrospective study led by David Gershenson and colleagues at MD Anderson Cancer Center, which looked at patients who had been treated at that institution for advanced low-grade serous ovarian cancer, had undergone debulking surgery followed by adjuvant chemotherapy. So those patients all received chemotherapy. And then some of the patients received hormonal therapy, endocrine therapy afterwards, and others did not. And then the retrospective comparison looked at those patients that had received endocrine therapy versus those that did not, and showed that those patients that received the endocrine therapy with agents such as letrozole, anastrozole, tamoxifen had a longer progression-free survival and overall survival than those patients that did not. And based on that, many of us have started giving aromatase inhibitor following completion of chemotherapy for these patients, or aromatase inhibitor alone in certain settings. But we don't have a specific end date. In fact, in the ongoing randomized phase 3 clinical trial, there also is no end date. So nothing really to guide that specifically, other than, of course, breast cancer literature, where generally the extent of these drugs is 5 to 10 years of maintenance therapy. So generally what I tell my patients is that, you know, we will expect to continue it for 5 to 10 years based on their tolerance. And of course, based on them not developing recurrent disease. We'll be monitoring for bone marrow toxicity and other side effects. But generally after 10 years of maintenance therapy, I would discuss with the patient if they wanted to discontinue that medication if we did not have a reason to discontinue it earlier.
Great. Next question comes from Giuseppe Cucinella. He's asking about surveillance. So Giuseppe, you want to proceed?
Yep. First of all, thank you for this comprehensive overview. My question is about the follow-up. So the consensus recommends close imaging intervals during the follow-up, especially in the first 2 years. So my question is, which imaging technique is the one to be chosen to best investigate potential recurrences? Thank you.
Yeah, thanks, Giuseppe. Of course, it differs by patient and by institution, but generally we recommend CT scan imaging with chest, abdomen, and pelvis CT scan every approximately 6 months. Though in patients that have residual disease, you might be doing that every 3 months at first. In patients with complete gross resection, every 6 months for the first several years, and then spacing out over time. And then for patients that do retain an ovary who had fertility sparing surgery, we generally follow that with a pelvic ultrasound.
Great, Rachel, thank you so much. I mean, this journal club is generating so many questions. I keep going from the chat to the questions from the fellows. Really good question. Can you speak a little bit about the role of bevacizumab in the either upfront setting or in the recurrent setting for low grade?
Yeah, I think it's something that we don't talk about enough. So there have been at least two retrospective studies looking at the use of bevacizumab in combination with chemotherapy in patients with recurrent low-grade serous ovarian cancer. One out of our group at MSK, another one from MD Anderson. And these showed surprisingly high response rates to chemotherapy plus bevacizumab in these patients with recurrent disease, like 40% response rates by RECIST criteria. And so bevacizumab is something that I really do like to utilize for these patients in the recurrent setting, either as a single agent with oral Cytoxan or in combination with chemotherapy, such as liposomal doxorubicin or paclitaxel chemotherapy. And then in the upfront setting also, it's definitely something that I think about adding to the chemotherapy for my patients, in particular, those patients who have residual disease and following as a maintenance therapy. So again, while we really lack a lot of prospective information here, and it's hard to do a prospective clinical trial now with something like bevacizumab that's really available to our patients, it is something that I do routinely use both in the upfront and recurrent setting for our patients, and something that I like to think about earlier in their disease course, since we want to give them that potential advantage before any future development of bowel obstruction or other complications.
Okay, so on the theme of recurrent setting, we'll go to Giuseppe Caruso, who has a question about this particular setting. Giuseppe?
Yeah, hi everyone. Congratulations on such a great paper. I just want to focus on the recurrent setting and ask you if there is any criteria that we can use to decide between surgery and systemic therapy, and in case of systemic therapy, which one we should use, chemotherapy, hormone therapy, targeted therapies like bevacizumab or MEK inhibitor. Is there any indication that we can follow?
Yeah, and see, with our patients with recurrent disease, of course, because these patients luckily live a long time, we oftentimes go through many different lines of therapy. So oftentimes we do like to consider surgery many more times in low-grade serous ovarian cancer than we would for high-grade serous or other high-grade histologies. And so the consensus panel really did emphasize that, well, with high-grade serous ovarian cancer, we really would be aiming for a complete gross resection at time of secondary or tertiary debulking. With low-grade serous ovarian cancer, we do feel there is benefit, even if there will be some residual disease left behind, to consideration of doing repeat debulking surgeries, because of the lower response rates to systemic therapy, and also because of, in some cases, the more indolent nature of this disease. So we do recommend that patients with this disease be considered for surgical debulking multiple different times through their disease course. However, of course, eventually most patients will no longer be a candidate for surgical debulking, and will be relying upon systemic therapy. And so the factors that we take into account are a patient's molecular profile and the behavior of their disease. So our patients that are younger, the patients diagnosed less than 35, are less likely to have a MAP kinase alteration and are more likely to have this more aggressive disease that can behave more like high-grade serous ovarian cancer. So those are the patients where I tend to go more quickly to chemotherapy in combination with bevacizumab. And if they're not showing response to endocrine therapy, I will move away from that strategy pretty quickly. It's our older patients that are diagnosed more in their 60s and 70s that are more likely to have a MAP kinase alteration and more likely to have more indolent disease, which can be maintained with endocrine therapy through multiple different lines of endocrine therapy, and who may have be more likely to have very long sustained responses to MEK inhibitors. So those are my general principles based on the patient's age. But I also do like to now consider the use of MEK inhibitors early in a patient's disease course, especially since they can have significant toxicity, ocular toxicity, edema, GI toxicity, cardiac toxicity. So better to consider their use when a patient is stronger and better able to tolerate those toxicities. So I generally do consider the use of MEK inhibitor in the second line or third line setting. And then for those other considerations regarding the use of chemotherapy, endocrine therapy, and bevacizumab, take into account whether they're behaving like one of these more indolent cases or one of the more aggressive cases.
Great. Thank you, Rachel. And since you're on the topic of managing toxicity, there's a really good question, I think, from the audience is, how do you manage menopausal symptoms in a patient who's on letrozole?
Yeah, it's so hard. And it's so hard for our patients because so oftentimes we're putting them through this surgical menopause that comes on so suddenly and can be very harsh in terms of the side effects. And so I always counsel my patients when they're going through their initial debulking surgery that's putting them into a surgical menopause, that we do expect them to have this sudden onset of symptoms, and that at first it can be very difficult to manage, but that we expect it will improve over time. And so we do try to push through that first month or two of treatment in hopes that things will stabilize over time in terms of side effects. And to best support our patients, we have early intervention with a sexual health expert to talk about sexual health and vaginal moisturizers. We have our patients start routinely on vitamin D repletion and discuss bone health. We talk about the importance of exercise, in particular interventions like yoga and gentle exercise, since we know that mobility is so important for preventing the joint pains that can occur with aromatase inhibitor. And for patients that have significant joint pains, sometimes use of a low-dose diuretic can help with the peri-joint edema that we can see with the use of aromatase inhibitors. And so we do try to have frequent interventions during those first couple weeks when the patient is first started on an aromatase inhibitor to help them to best receive supportive care so that these side effects do not feel intolerable, and that we can hopefully get them to that more manageable state.
Great. This next question comes from Guido Balsacchi. He's in Argentina. Guido.
Thank you very much, Dr. Grisham, for all the answers. My question is somehow similar to Seda's one, but a more specific question. As stated in the consensus, NCCN guidelines, ESMO guidelines, represent the currently standard of care management as for primary systemic therapy. So based on your experience, which of the suggested regimens would you offer to a 35-year-old woman with no comorbidities, with a stage-3 low-grade serous ovarian cancer after a complete cytoreductive surgery? Thank you.
Yeah, thank you. So that kind of goes right between those two scenarios I was talking about, because 35 is right on the cutoff of between where we define the younger, more aggressive disease and the older, sometimes more indolent disease. They have stage 3 disease, but they've had a complete gross resection. For someone like that, historically, I generally would offer chemotherapy with 6 cycles of platinum taxane chemotherapy followed by letrozole maintenance. But I can't definitively say that that's better than letrozole alone, because we have this ongoing clinical trial that's hopefully going to give us that answer. But generally, in my personal practice, for somebody like that, I historically would offer them chemotherapy followed by aromatase inhibitor, with just the reason being that this is our chance for cure, and I want to be as aggressive as possible.
Great. So Rachel, one last question, respective of your time. So this is obviously a global journal club, and we had over 77 participants today. But you brought up the point of HIPEC, and as you mentioned, the use of HIPEC in low-grade ovarian cancer. Important topic. What are your definitive and conclusive remarks about HIPEC?
Well, our rationale as a consensus conference for advising against the use of HIPEC outside of a clinical trial for patients with low-grade serous ovarian cancer is based upon the less chemo-responsive nature of this disease and the lack of any clinical trial data to support its use at this time. And so we would prefer to offer these patients molecularly targeted options or enrollment to a clinical trial or bevacizumab over the use of HIPEC.
Fantastic. Very well. Well, Rachel, again, incredibly informative. Always is a pleasure listening to you, and learn so much. Thank you for taking the time to spend with us and discussing this paper. Thank you for the podcast, and congratulations to you and everyone who participated in this state-of-the-art consensus statement.
Thanks so much. It was really a pleasure, and I enjoyed all the questions. So thank you.
Fantastic. I just want to also remind everybody the October Journal Club, we would love for you to join us, and it's going to be with Dr. Nuria Agusti, who is going to be speaking about sentinel lymph node detection in early stage ovarian cancer. Thank you all so much for participating and joining us and supporting the journal.
Thank you.